So thank you very much, everyone. I'm going to use my 10 minutes to marshal some of the evidence around some of the major goals and objectives for a Pharmacare system that have been discussed over the last day and a half. And I'm going to try to provide, I think, a somewhat optimistic view of there is a prospect for reform in the near future, and that reform can save money and actually improve the performance of the system, and probably actually appeal to multiple stakeholder groups if it's done right. So first of all, Canadian Medicare, we're all intimately familiar with what this means. It's a deeply felt part of our identity as Canadians and as members of any particular province or territory of this country. We have a universal system for financing medically necessary hospital care and physician services. The problem is, in a sense, or the problem that we're here to talk about today, is that that universal system of funding medically necessary care ends as soon as a doctor hands a patient a prescription. Pharmacare in Canada is, in a sense, a work in progress. The fathers of our Medicare system as we know it in the 1960s had envisioned that we would have a national or a universal national program for pharmaceutical coverage that would provide more or less first dollar coverage for all Canadians. But we didn't quite get there. So in a sense, what we have now is a piece of unfinished business. And it's not to say that provinces on their own haven't built programs to try to meet needs of their populations. They certainly have. In fact, we have a myriad of pharmacare models in this country today. I'm going to highlight three of them as sort of the typical models, or maybe sort of typical models of the major designs of drug benefits in Canada as we know it, and I'll compare those to a couple of examples internationally. Because we're here in British Columbia and because I've done a lot of research in this area, I will focus in part on British Columbia's model of catastrophic drug coverage. It's a model of drug benefits that's designed around the idea that no person should have to break the bank to afford the medicines they need. So in effect, it's universal, but it's universal only against catastrophically high drug costs that are defined as a percentage of your income, typically 3%, possibly 4%, depending on the amount of money that you have to pay out of pocket after deductibles. Ontario's model is probably the classic model of provincial pharmacare programs in Canada, and the model from which many provinces are wondering whether or not they should move. It's a model that is structured around protecting society's most vulnerable, notably senior citizens who historically at least were shorthand for low income and high health care needs, and protecting persons with the lowest incomes, that is, the persons on social assistance. Ontario also notably has an income-based safety net for all non-seniors should their expenses exceed thresholds of income, which for that province is 4%. And then we've heard about Quebec already in this conference, but this is another model of pharmacare and one that is being looked at seriously by other provinces. And it's a model structured around an insurance design. It effectively means that you are required or compelled to purchase private insurance if you are an employee of a company that offers extended health benefits. If you cannot obtain private insurance through your work or occupational status, you are required to purchase what looks like an insurance program from the government. It includes premiums, deductibles, and co-payments in a manner that is comparable to what you would expect of a private plan if you were employed in a different province. I'm going to compare those Canadian models against a couple of international examples, and just to keep this as quick as possible, I'm going to compare us to the Netherlands, which is a model a little bit like Quebec in that it is a system of compulsory social insurance. However, it's compulsory social insurance for all of healthcare. So the social insurance companies that compete for your business in insuring you or your occupational group compete to insure all of your costs, not just drugs, but hospitals, physician services, medicines, and actually other care as well. I'm also going to compare us to the United Kingdom, which many of us are familiar with, which is a true public healthcare system, which is comprehensive of medical, hospital, pharmaceutical, and other forms of care. Both the Netherlands and the UK have little or no co-payments and universal coverage through those different designs. So how do we perform on access to medicines? And I'm going to look here at the percentage of the population that report that they have to either skip doses, in a sense stretch their prescriptions, or actually not fill their prescriptions because of the financial barriers that they face. And here you can see, and we're in the province that performs worst of all in Canada, and probably worst of all in any comparable system in the world. We have over 15% rate of cost-related non-adherence to medicines in British Columbia, It probably owes to the fact that our public payer is a payer of last resort. It kicks in after you've filled many prescriptions, but it doesn't kick in at the very important point, which is when you're filling that first prescription, perhaps for the chronic conditions that you might have or for the new ailment that you've suffered. Ontario and Quebec do comparably in terms of cost-related non-adherence in Canada, and nationally we have about a 10% rate of financial barriers to accessing needed care. The Netherlands and the United Kingdom, as you can see here, by way of universality with little or no cost to patients, have remarkably low reported rates of cost-related non-adherence. They have remarkably little barriers to accessing care, and I think that's critically important when we recognize the #1 goal identified by this diverse audience in terms of what Pharmacare should do is promoting access to care. These models clearly outperform us on that measure. What about financial equity? And here I'm going to particularly focus on protecting people who have high needs or are needs for high-cost medicines, the extent to which they may have to pay $1,000 or more out of their pocket for those medicines. And this is an interesting portrait in Canada. We see British Columbia and Quebec having relatively high rates of financial vulnerability or having patients having to pay fairly high rates of prescription costs out of pocket. The British Columbia case probably stems from the fact that we have a system that the universal program kicks in after income-based deductibles, and we actually have slightly less private insurance in this province owing to the composition of manufacturing and financial jobs in this province. Quebec, interestingly enough, has fairly high rates of financial vulnerability, probably owing to the fact that by structure of their program, although benefits kick in at the first prescription, they actually have fairly significant cost-sharing arrangements with them. And it's possible that these patients are also reporting costs for medicines not covered by the plan or costs for drugs that they may use over the counter to avoid prescription charges. Again, I would just point to the Netherlands and the United Kingdom as examples of countries where very few people, virtually none in a statistical sense, face these significant out-of-pocket burdens as a function of cost. I just want to talk a little bit about the structure of our catastrophic program in British Columbia and the model as it is spreading across the country. It is structured against this idea that no person should have to bear a financial burden that is undue relative to their income. And it's structured in a model that's comparable to thinking that insurance for pharmaceuticals is like insurance for fire or theft in your home. The reality is, actually, if you have chronic needs, if you are experiencing $1,000 or more out of pocket, or 3% of your income out of pocket for medicines, you're probably going to experience that year after year, perhaps until death. We've talked a lot about efficiency. I'm going to go through this very quickly, but this notion of how can you marshal or manage the expenditures in a system to obtain value and keep them under control. Canada does not do particularly well in comparison to other countries. Across Canada, British Columbia has the lowest level of spending on prescription drugs in Canada. It's notably, it actually currently has one of the fastest growth rates for spending on prescription drugs, in particular in the private sector, as public spending is kept under control, in large part because of the income-based structure of our program. It pushes a lot of costs into the private sector. The Netherlands and the UK, just to give you an example, if you were to have their level of spending at a national level for Canada, if we were like the Dutch, we would be spending $10 billion a year less on prescription medicines in this country. And if we were like the Brits, we would be spending somewhere on the order of 14, perhaps only 12, but $12 to $14 billion a year less on medicines than we do today. What about research and development? What about fostering innovation? If we spend a lot per capita on medicines in this country, do we get a lot in terms of R&D? Unfortunately, the answer is absolutely not. In comparison to, for instance, the Dutch or the Brits, we have far fewer dollars of R&D in the pharmaceutical sector than they do. If you, again, at a national level, this is tantamount to losing out on about $1 billion worth of R&D investment if we were like the Dutch, or remarkably, about $3 billion of additional R&D investment if we were like the Brits. So what about choice? Interestingly enough, no system in the world covers every single prescription on the market, certainly no system that's comparable to ours. However, it is notable that the Dutch and the British systems do have relatively open formularies. In fact, the British system effectively has no formulary in the sense that it basically requires, it has a negative list that actually list medicines that would not be covered, but otherwise, by default, everything's up for coverage. But the key thing with both of those systems, the Brits and the Dutch, is that the systems that finance medicines also finance the payment for physicians and hospitals. And so those actors that are responsible for writing prescriptions also know that the costs of those prescriptions are coming out of the financial envelope that pays their salaries. Now, if you make those financial incentives too close to the practitioner, you can get problems. But if you do it at a system level, perhaps at the equivalent of a health authority for Canada, you can perhaps get incentives for prescribing that is cost-effective in terms of encouraging generic utilization as first-line therapy. I want to talk briefly about the product listing agreements that Canada is increasingly using and are increasingly becoming normal around the world. IMS Health expects or predicts that approximately $75 billion US dollars of off-invoice rebates from branded manufacturers are being paid to insurers around the world. This is a new global paradigm for pharmaceutical pricing, which is an important change in how we think about the structure of drug benefits. It's also an important opportunity to open the formulary. If it's done right, and particularly if it's done in a way that you can tie the indication for use to the extent of the rebate from manufacturer, you may actually be able to allow there to be a broader formulary where the manufacturer is rewarded with a lower rebate when the drug is prescribed to patients for whom it is truly cost-effective, and the manufacturer pays a bigger rebate to the insurer where the drug is being prescribed in indications for which it's not so cost-effective. It's impossible to manage a system like that, a patient-centered system like that, if you silo pharmaceutical coverage from the rest of your healthcare system. And I think we need to be mindful of that moving forward, that we could have a win-win deal if we could bring these things together in a patient-centered envelope, linking our data and our financing systems in a way that was truly a win-win for industry and patients. We know that on the global scale, roughly about $100 billion worth of medicines are coming off patent and have been coming off patent in recent years. This is referred to as the patent cliff for the pharmaceutical industry. It actually presents a tremendous opportunity and challenge for pharmaceutical policymakers around the world. Canada is going to have to confront its rate of generic use and its rate and the extent to which it pays relatively high generic prices in the near future, because there are literally billions of dollars of savings hanging out there to be picked. And I think a system for Canada, in fact, through, say, a universal tender at a provincial level, could actually afford to give every resident of a province free prescription drugs for generics at lower cost than we currently underwrite just the cost, for instance, for seniors alone. And there's a paper by Mike Law and myself and others that outline how this might take place, and there is evidence to suggest that we could actually provide universal coverage for generics alone and save public money. So the big question is, how do we move forward? There's no question that there is evidence to suggest that a system that was more integrated and more comprehensive would save money and improve access. The question for us now, moving on for the rest of the day, and I think after this meeting, will be, how do we mobilize people so that they see that there's value for money here and that they see that there's possible win-win solutions for the stakeholders? Thank you.